So, good afternoon, everyone. On behalf of BLK Center for Child Health and IAP Center City Branch, I, Dr. Swati, welcome you to this BLK TELE-PEDS webinar. As we know, stridor in infants is not uncommon and the causes vary. And today we are going to have a panel discussion on an uncommon but treatable cause. Uh, to moderate the session, I welcome Dr. Ankit Parakh. He is Associate Director, Pediatric Pulmonology and Sleep Medicine at BLK Center for Child Health. And in the panel, we have with us Dr. Gaurav Garg, Associate Director, Pediatric Cardiology, and Dr. Tarun Raina, Cardiothoracic and Vascular Surgery, Senior Consultant, and Dr. Ritika Goyal. She is Consultant Pediatric Pulmonology at BLK Center for Child Health. So over to you, Dr. Ankit, for starting the session.
So thank you very much, Dr. Swati. So we'll discuss about stridor in children today. And we all know that stridor in children can be because of various causes. Right? So the most common cause, as we understand, of stridor in children is laryngomalacia. And we all tend to think that all children who present with stridor or a congenital stridor, which tends to persist, would be laryngomalacias. Right? But we all know that there are different causes of stridor, which is present since birth. And we'll try and show you a few cases or a series of cases who presented with an alternate cause. So if you look at children with stridor, then you will have a group of children who are otherwise well. They have a mild stridor. They grow well. They do not have significant amount of respiratory distress. And they do not require any breathing or respiratory support. But there is always a group of patients who are sick, who require some respiratory support. They have significant retractions. They have failure to thrive as well. And this is a group of patients where the chances of having alternate causes are much more. So today we'll show you an unusual cause, but still treatable. So we'll show you a series of patients who presented with an alternate cause, and we'll talk about it. So we have three short talks here. The first would be by Dr. Ritika Goyal, who will speak on the respiratory manifestations. Then we'll go on to a talk by Dr. Gaurav Garg, who will show you the cardiac manifestations. And then how do you treat them? So we have Dr. Tarun Raina, who is a senior consultant and a pediatric CTVS surgeon who usually operates upon such babies. So let's start with the first talk by Dr. Ritika. And you can type your questions in the chat box and we can take them either after the talk or at the end of these three talks. So I think, Dr. Ritika, you can take over. Ritika, you're not audible.
Yeah, Ritika is not audible, I think.
Ritika, I think you are on mute. Please check.
You have to write, I think she not listen.
Sorry,
Now it's okay.
I'm sorry, I'll start again. I think I was on mute. I forgot to unmute myself. So we'll start with the first case where I'll be discussing the respiratory presentation of this cause of stridor. We had a full-term normal vaginal delivery, good weight, appropriate for gestational age baby who had respiratory distress at birth. He was admitted in NICU on day 1 of life. On examination, the baby had stridor, subcostal retractions and tachypnea. On exam, the chest was clear and the chest X-ray was unremarkable. This baby required nasal CPAP with a PEEP of 8, and we were able to gradually reduce the PEEP to 5. This baby never required supplemental oxygen. He was maintaining his SATs at FiO2 of 21%. The sepsis screen was negative. However, this child had 3 failed attempts of weaning from CPAP. Every time that the baby was put on HFNC, the respiratory distress increased, and this is the clinical video of the baby. So we can hear that there is a stridor. I hope everybody can hear that. And there are significant subcostal retractions and tachypnea, which increased as soon as the child was weaned off positive pressure ventilation. So this patient was referred to us at BLK-Max hospital. And first of all, I would like you guys to take a minute and think that, would you suspect airway issue in this baby firsthand? Now we have a good weight baby with respiratory distress at birth, significant respiratory distress, and need of prolonged positive pressure ventilation. So although there is a stridor, but this is not a regular benign stridor that we see in laryngomalacia. So what can be the causes for this kind of a severe stridor at birth? So it can be a severe laryngomalacia because they can present like this. Then it can be a vocal cord palsy, subglottic stenosis, airway malicias, or extrinsic compression of the airway. So we'll find out. This patient was referred to us at BLK and we did a flexible bronchoscopy. And in the bronchoscopy, we could see the upper airway was fine, but in the trachea at the carina, there was significant narrowing of the airway. And the narrowing continued inside the left main bronchus as well. In the video right now, we can see that the trachea is compressed. It is not round, but oblong. And if we look closely with the baby's efforts, the narrowing is not opening. So there's no dynamicity. That's how we differentiated malacia from an extrinsic compression. This is a fixed narrowing of the trachea and the left main bronchus. And as we went inside the left main bronchus, the further segments inside the left main bronchus were fine. So the benefit of doing bronchoscopy here was we could diagnose a fixed compression of the airway. We could know the severity, that the occlusion was more than 50% of the lumen, and the extent of the obstruction, which of the parts of the airway were involved. So because we suspected extrinsic compression, we got a CCT chest done. And this child had a double aortic arch. Now this here. So this here is the right side aortic arch, which is coming and compressing the airway at the carina and the left main bronchus. The airway is compressed between the right aortic arch and the descending and posteriorly by the diverticulum. So this was one presentation of a baby in the newborn phase with an unusual cause of stridor, which was vascular ring. Now let's come to the second scenario. We had a 2-year-old girl with symptoms starting at 6 months of age. She had persistent cough, recurrent episodes of wheeze where she required nebulizations. And she had poor response to bronchodilators as well as inhaled corticosteroids given by inhalers. She was put on controller therapy with very poor response, and she had failure to thrive. On examination, she had bilateral wheeze, and classical history that the mother gave was that she's never been well. There have not been an episode where she has not had any cough. On the X-ray, it was unremarkable except for a little bit of hyperinflation that we could see. So in this case, the pointers towards an atypical wheezer was persistent symptoms, never been a well period, had poor response to SAVA, had failure to thrive. So we went ahead and we did a flexible bronchoscopy to figure out what's wrong with the airway. And what we found was there was a fixed obstruction in the airway, even in this case. So this is a lower part of the trachea where we can see that there is some narrowing in the right side. And this narrowing is fixed. It's not opening up with the efforts of the child. So that tells us that there is a fixed obstruction or extrinsic compression, mainly from the right side of the trachea. So we got a CT chest and we found out that this child also had a right-sided aortic arch and an aberrant left subclavian artery. Now, what we can see in the figure on the left is the right-sided aortic arch, and this is the pulmonary trunk, and this is the descending aorta. So there is compression between these two structures. And in the next figure, what we see is a comeral's diverticulum. A comeral's diverticulum is a remnant of the fourth aortic arch, where the diverticulum arises from the descending aorta, and it goes behind the airway and the esophagus. And from there, it compresses the esophagus and the trachea posteriorly. So this child also had significant airway compression because of abnormal vasculature and presence of a vascular ring. So vascular rings are congenital vascular anomalies of the aortic arch complex that form a complete or a partial ring and compress the trachea or the bronchus or the esophagus, leading to symptoms. These anomalies are usually are because of abnormal dissolution of the aortic arches in utero. And because of that, the big vessels, the great vessels of the heart are either anomalous or they have an aberrant pathway, and they go and compress the structures in the mediastinum. They comprise 1% of cardiovascular congenital anomalies, and the overall prevalence of the vascular rings is 3 to 5%. Now, when the most important question is, when do we suspect a vascular ring or a anomalous vasculature in the heart? See, we all deal with children who we all deal with wheezing children in our day-to-day practice. But what are the clinical pointers of an atypical wheezer? Most of the children with vascular anomalies have respiratory symptoms predominantly, and they have some esophageal symptoms or feeding symptoms. Now, the mean age of presentation is usually 4-5 months to 4.5 years. But as we have seen in the cases presented to you, they can very well present in the newborn period as well. And there have been reported cases of adults being diagnosed at 45-50 years of age with vascular rings. So what we usually see is the younger babies, children who present in infancy, come with respiratory symptoms, like they can have ALTEs or apneas. They have an inspiratory stridor at birth. They might require positive pressure ventilation for prolonged periods. Atypical wheezers. They have a very classical seal barking cough because the compression is in the upper part of the airway. So they have a chronic cough, which is like a barking cough. They can come with recurrent respiratory infections, and if they present later in life, they can even have suppurative lung disease because of airway obstruction. They can have a hoarse cry if the obstruction is more proximal. A lot of times, these children are misdiagnosed as asthma and are treated with inhaled corticosteroids with poor response, as we saw in our second case. Now, coming to the feeding symptoms, which are also very common in these children, but they usually become apparent as the child grows older and the solids are introduced in the diet. Once the solids are introduced, the most common symptom is dysphagia. Parents usually say that this child is the last one to get up from the table. He's a slow eater. He's a fussy eater. It's because the child might be having dysphagia. These children early on can have issues with breastfeeding, bottle feeding. They can have fatigue. They can have symptoms of aspiration like regurgitation, emesis, even pneumonias. And they have failure to thrive, which can be because of dysphagia, food intolerance, food avoidance, and also because of recurrent respiratory infection, increased respiratory effort, multiple reasons for them to have failure to thrive. So if you have a child who's wheezing and not responding to your controller treatment, is sick, has failure to thrive, has any kind of noisy breathing, then we must think of this cause. We must think of vascular rings as well. So dysphagia, so when we have an aberrant right subclavian artery, the dysphagia associated with that is called dysphagia lusoria, which was termed by a gentleman, David, a long time back, because he described this kind of dysphagia in children with vascular anomalies. And this is a review of literature of various symptoms that have been reported with in children with vascular rings, where airway symptoms are predominant. More than 90% of children in all these studies had airway symptoms, while the esophageal symptoms were not so common. One important thing to notice that stridor is seen in only 50%, around close to 50% of patients. So stridor is not a constant feature. It is not a must symptom in a vascular ring, despite there being a tracheal compression. A lot of times vascular rings are associated with other cardiac anomalies and respiratory anomalies. Structural congenital cardiac anomalies are seen in 12% of cases with vascular rings, and most common amongst them is tetralogy of Fallot. They can have syndromic associations like DiGeorge syndrome as well. Pulmonary artery sling is associated with complete tracheal rings. This is an association that has been reported. And these children can have concomitant airway malicias because of chronic compression, in utero compression, and these things must be tackled during surgery or after surgery. How do we confirm how do we confirm vascular ring? We all have discussed this. The first investigation that we do is flexible bronchoscopy because it confirms a diagnosis. It helps in locating the compression, assessing the severity, and even the complications of chronic compression. However, the most diagnostic and confirmatory investigation is CT angio, where we can delineate the vascular the anomaly, the anatomy of mediastinal structures, and it helps in preoperative planning. Post-operative issues, there are a lot of respiratory issues in the post-operative period as well. Like patient might have inability to wean off from positive pressure ventilation because of residual airway malicias, which cannot be determined in preoperative bronchoscopies. In post-op bronchoscopies, we have found cases of vocal cord paresis also, which is common complication of surgery because of injury to recurrent laryngeal nerve. And of course, these children can also have pneumonia. So these complications need to be tackled, and post-op bronchoscopy is also essential. So my take-home message will be that vascular ring is a very difficult diagnosis for a pediatrician because it has a heterogeneous and non-specific respiratory and esophageal symptoms. We need a high index of suspicion. Stridor is not a universal symptom in these patients. We have to keep our antennas high when we have atypical visa. Bronchoscopy has pre-op, intra-op, and post-operative utility, and respiratory complications after surgery need to be managed adequately to give them a good quality of life. Thank you.
So thank you, Dr. Ritika, for the nice presentation. I'll just try and summarize what we are trying to say. So we've shown you two infants who have presented with an alternate cause of stridor, which is a vascular ring. So the first point which we all need to remember is that if you have a child who presents to you with a persistent wheeze, which is not behaving like
I think we lost. Maybe we can maybe we can continue with Dr. Gaurav's presentation, and then Dr. Ankit can join back. I think he has some network issue. So, Dr. Gaurav, maybe you can start your presentation.
Yeah, good evening, everyone. Am I audible?
Yes, yes, you.
Yeah. My slides are visible, ma'am?
Yes, but you need to go on presentation mode. Present.
Are it okay?
Yeah, yes.
Let's continue where Ritika left. She has told that many patients come with respiratory symptoms. Although most of the patients of vascular rings, they come with respiratory symptoms. But sometimes there can be dreaded complications that we have seen. So let's discuss two cases, then we can discuss about it a little bit more. And so let's start with case one. So a baby girl, a newborn, 19 days old, she had a cardiac arrest in somewhere outside OPD, and she had some URI and fever. Then the parents took her to the OPD. There she had a cardiac arrest. She survived. Luckily, she survived after a brief CPR. She was put on ventilator and shifted to our hospital. So we thought that there was primarily seizures or hypoxia, which was the cause of this arrest. So EEG was done, neurologist was involved, and baby was kept in the ICU. So she was extubated and put on NIV support. But neurological examination was normal. He didn't have any evidence of seizure in the EEG, and baby was extubated normally. And but there was one cardiac finding that she had a murmur, and chest X-ray also showed some cardiomegaly. Although she was put on anti-seizure medication in view of the suspected seizures in the OPD. So echo was ordered because of the murmur and cardiomegaly, and echo showed a large PDA with a right-sided aortic arch. So, but this was not looking normal. This right-sided aortic arch and the left-sided PDA, it was not looking normal to my eyes. There was some abnormality that was stuck there in my mind, that it has to do something with the vascular ring. But in echo, we could see there was a left-sided PDA and a right-sided aortic arch. And when we see these kind of echoes, then we are almost sure that we are dealing with some kind of a vascular ring. And that is, again, it can be a complete ring. So our mind started thinking about a vascular ring, and the cause of cardiac arrest maybe was that. The CT angiogram was ordered. The CT angiogram showed a right-sided aortic arch with a large diverticulum arising from the descending aorta. It was going behind the esophagus, and it was attaching to the main pulmonary artery on the left side. So thus forming a complete vascular ring. So forming a complete vascular ring, we need to have encircling the trachea from all the sides, from the right side, from the left side, anteriorly and posteriorly. So in this case, the right-sided aortic arch is on the right side, the ductus arteriosus is on the left side, main pulmonary artery is on the anterior side, and the diverticulum, which is a big diverticulum, this is on the posterior side, and thus forming a complete vascular ring in that baby. Bronchoscopy was done by Dr. Ankit, and it also revealed a significant tracheal stenosis. This is a CT picture of the baby, which is showing this is the large diverticulum. See how big it is. It is bigger than the aortic arch. So this is the aortic arch of the baby, and this is the diverticulum, which is going posteriorly from the trachea and the esophagus. Even the left subclavian artery is also rising from this big diverticulum. And this is the picture of the trachea in the CT. See how narrow it is in the midline, in the middle. So this is the tracheal stenosis shown in the CT. And this is the picture, 3D picture of CT showing the trachea in the middle. So this here is the trachea, and in this here is the trachea, which is found in between these vascular structures. So finally, we got our diagnosis and the cause of cardiac arrest in this baby, which was hypoxia due to compression of the trachea. So obviously, our pediatric cardiac surgeon, Dr. Tarun, was involved, and family was counseled, and he performed a wonderful surgery on the baby. And just after 5 days, we could discharge the baby in a perfectly well condition. Now she is 6 months old, and just few days back, I think 1 week back, she came in the OPD. She is neurologically normal. We have stopped the anti-epileptics, and there is no further episode of hypoxia or seizures. Milestone wise, she is perfectly normal. This is the baby. She has started sitting, and she is looking normal. Now the case 2, newborn baby, and he was antenatal diagnosed as a double aortic arch in fetal echo, and the delivery was done at BLK hospital in view of high risk delivery, and we attended the delivery. Baby was attended by us also along with neonatologist, but baby was asymptomatic at birth, and elective echo was done in view of the double aortic arch, but it was not a double aortic arch, it was a right aortic arch with a left PDA. It almost looks like a double aortic arch, but diagnosis is a little bit different. The CT was done, so it showed, again, it is almost a similar case like a previous one, but a little bit of difference. Large diverticulum from the descending aorta and going posteriorly to the left side of esophagus and trachea. But there was abnormal takeoff of left innominate artery, although it was normally attached to the arch of aorta, but takeoff was abnormal, and it was adding to the formation of the vascular ring in this baby. So it was again a complete vascular ring compressing trachea and esophagus. Bronchoscopy showed 70 to 80% tracheal compression. Baby also started developing mild intermittent stridor. So team meeting was held, parents were also involved, and again we did a elective repair in this case in view of significant narrowing of trachea and possibility of sudden cardiac death if left untreated. The surgery was successful. Baby was discharged 7 days after surgery, and he is also doing fine with no symptoms and no issues 4 months after follow-up. So vascular ring, as Ritika told, that it is a abnormal development of the aortic arches, and due to which the vascular rings are formed. Normally, our first, second, and fifth arch involutes, and we have 2 arches going parallel in the embryonic life, out of which the right-sided arch disappears, but the left-sided remains. That forms a left-sided aortic arch, which is normal. But in some cases, the aortic arch is right-sided, which is again a normal variant of the aortic arch. But if both the aortic arches persist, then it forms a double aortic arch. And there are some variations of double aortic arch, like a right-sided aortic arch with left-sided PDA, and the apparent left subclavian artery with a combrous diverticulum that also forms a complete vascular ring. So halt in the development of aortic arch will lead to double aortic arch, and that is due to persistence of bilateral fourth arches. So complete vascular ring, here are some examples like double aortic arch, as I told you, is the most common cause. And again, the right aortic arch with retroesophageal component like ligamentum arteriosum and subclavian artery with ligamentum arteriosum, brachiocephalic artery. If they are big in origin, like a combrous diverticulum, they form a complete vascular ring. Otherwise, right-sided aortic arch with apparent left subclavian artery, it doesn't form a complete ring. It only indents the esophagus or trachea, and we should not do anything in these cases unless the symptoms are there, because it is a type of an incomplete ring. So in incomplete ring, we don't have to do anything because there will be no complete encircling of the trachea or the esophagus, and the patient is all right. Again, they can live very well up to adult life for 40 years, 50 years, 60 years, or even for the whole life also till the symptoms appear. As Ritika told you that she has seen patients in 40 years, 45 years, 50 years. So they are probably the patients of incomplete vascular rings, which is found by right-sided aortic arch and the apparent left subclavian artery, which only indents the trachea or the esophagus. So making a complete diagnosis is very important, and that can be done with the help of echo, CT, and obviously the third one is bronchoscopy. So the symptoms are already told by Ritika that there are mainly a respiratory symptoms or a digestive system symptoms, and but one thing we should keep in mind that there can be a sudden cardiac death in these babies. So which is now known as BRUI, brief resolved unexplained event, which can happen with these babies. So as we know that it consists of approximately 1% of congenital heart disease. We know that congenital heart disease occurs in 1 out of 100 cases, and it constitutes of those cases in which it involves only 1%. See, if we have 100 babies of congenital heart disease, one baby will have a vascular ring. So that is a very rare disease, but we should know about the disease and the symptoms and the catastrophe it can cause due to its nature. So current indications for surgery, as we know that if there are symptoms, if there are airway obstruction or a GI compression, then we do a surgery to relieve these symptoms. Thanks a lot.
Am I audible?
Yeah, you are audible.
Yeah. So thank you, Dr. Gaurav, for the wonderful presentation and the wonderful work which you are doing. And we have shown you a few patients of vascular ring, right? So let's bring in Dr. Tarun Raina here. He's a pediatric CTVS surgeon with BLK Hospital. And let's hear him out, and then we can have a discussion on vascular rings in children. So, Dr. Tarun, you can take over, please.
Yeah, good afternoon, everyone. Am I audible?
Yes.
Okay. Thank you, everyone, for this opportunity. Most of it has been covered by Ritika and Dr. Gaurav. And as rightfully said, it is a very rare illness. So the scope of this discussion that will so we'll go through this presentation in the following topics. Okay, so first of all, we like to define what vascular ring is. It is a congenital anomaly in which an aortic arch and its branches completely or incompletely encircle and compress trachea, esophagus, or both. So it is self-evident, but there has to be a definition for it. Again, Dr. Gaurav has explained you about the aortic arches, but having a diagrammatic representation of that would make things a bit more clearer. So this presentation will be more about how the aortic arch looks like, because surgical part is not very difficult. It is actually the anatomy which has to be understood. As you can see, this is how, which you can see, which are interconnected with intersegmental arteries. So what Dr. Gaurav already said, that the first, second, and the fifth aortic arch, it usually degenerates. The first remnant just leaves a part of maxillary artery. The second part is a small stapedial artery in our ear, gives rise to that. Third, fourth, and sixth are the main arches which lead to develop entire vascular supply above the level of aorta. So I'll not go into a lot of detail, but what we need to know is that the fourth aortic arch forms the fourth embryological arch forms the aortic arch. The fourth one on the right usually forms the innominate and the subclavian. So if this is how a normal circulation look like if the resolution of the arches goes in a very planned manner. Now, how do we classify? We again This is a slide which Dr. Gaurav has already shown, but the vascular rings are classified in either it is complete or incomplete, meaning it completely encircles trachea or esophagus, or it only partially encircles the trachea. The things will be more clearer when we go into the anatomical diagrams of these arch. So the complete vascular ring is again reclassified into double aortic arch, then right aortic arch with retroesophageal components. Then we have a very rare like a left aortic arch with right descending aorta, and a cervical aortic arch where embryologically the aortic arch does not arise from the fourth embryological arch, but from the third one. So coming on to the diagrams, this will give you an idea of what a double aortic arch looks like. So there you can see two arches. Encircling is the aorta crosses over the left side of the, what we labeled as a left arch is when the aorta crosses the left bronchus. And when the arch of aorta crosses the right bronchus, that is called a right arch. Invariably, the descending aorta in most of the cases is on the left side only. So this you can clearly see and visualize the compression of the trachea and the esophagus between these two arches. So this is what we embryologically we call as a double aortic arch. Now, a right aortic arch is an anatomical anomaly, but usually does not cause any symptoms. So this is how a right aortic arch looks like, where you have a remnant of the left joins a brachiocephalic. This is called a mirror imaging branch. If you imagine, this is just opposite to what a normal anatomy looks like, where you have a brachiocephalic artery on this side, common carotid on this side, and left subclavian on this side. So this is the mirror image branching. And this gives rise to a PDA remnant which comes off from the brachiocephalic artery. So far, the patient of this kind of patient usually may present for any other illness, but not for a complaint of vascular ring. Now, there are from 1 to 4. So, type by
I think there is some network issue. We are trying to get the slides back on.
I think we can take some discussion points from the audience as well till Dr. Tarun is getting the slides back.
There is a question in the chat box. What is the role of steroids in such cases of inspiratory stridor?
Here in this case, what is the role of steroids in stridor is when we're suspecting any kind of edema in the upper airway. That's where we give steroids, like in post extubation when we're suspecting any subglottic stenosis or any kind of airway edema. In that situation, we give steroids. So in this particular scenario where we are suspecting where it is a compression, extrinsic compression of the airway because of a vascular ring, I don't think there is any role of steroids. Steroids in Stridor is very useful when we have airway edema. No, not in vascular rings. Any points you would want to add, Dr. Gaurav?
I don't think there is a role in these cases. The compression is from the outside.
Yeah.
The role of steroids.
In fact, even in tracheomalacias, airway malasias, there is no role of steroid in airway malasias.
So we have to correct the anatomy.
Yeah.
There is an anatomical defect. So if we correct it, then the patient will be fine. Steroid can't help me.
One thing from Dr. Gaurav's presentation, what I would like to comment on is importance of fetal echocardiography and early diagnosis of vascular rings. Now, with advancement in the field of radiology and fetal ultrasounds, I think we are if we are way ahead of the disease, then it definitely improves the outcome. What is your say?
Yeah, fetal echo is very important. Nowadays, we can diagnose most of the vascular rings in fetal echo. We are diagnosing these cases because I think in past 6 months we have diagnosed 5 or 6 cases of vascular rings. So it's good if we can diagnose these cases and these babies can be delivered at a tertiary care center where pediatric cardiac and neonatology services and pediatric pulmonology services are available. Then this will be good for these babies.
The intervention is the key, and if we are able to diagnose them early, the morbidity definitely reduces. Swati, could you connect with Dr. Raina? What is is he coming back?
यही है कॉलोनी में कह रही है कॉलोनी के 2 किलो ले रखी है कौन कह रही है मुझे यही नीचे रखेगा
Dr. Ankit, you are on mute.
Dr. Tarun has joined back and he's trying to share his slides now.
Dr. Ankit, you are on mute. We can't hear you.
Tarun is trying to share his.
I think Tarun has joined back.
Yes, he has joined back and I spoke to him. He's trying to share the slides.
Okay.
One more point that I would like to discuss here till Dr. Raina is joining back. Okay, he's here.
पहले तो मुझे इतनी नहीं थी तो मैं हथेली दबा कर तो मैं सामने लगा देती थी
Yeah, Ritika, hi.
So, yes.
Where exactly did I lose the slide?
I think you were discussing about the anatomy. The diagrams were coming up from double aortic arch.
So, Acha, it is after double aortic arch, is it?
Yeah, yes.
Oh, it's a long way back. Sorry, I didn't realize that I lost I was so into this. Okay, again, is this the slide you're talking about?
Yes, yes, yeah.
Okay, so now is it available?
We
So
can
this is how anatomically a double aortic arch looks like. So you have a right aortic arch and a left aortic arch, and this is the area where there is compression of the esophagus and trachea. Then again, we have a common type of right aortic arch with mirror branching. This, if you can see this diagram, this is inconspicuous anatomy. It won't cause any problem. Here, the aorta is giving rise to a right arch, and there is a left brachiocephalic artery giving rise to ligamentum arteriosum. This per se is a benign condition. You won't even find it unless they don't come for some other problem. Now, then there are variations of these types where you have a retroesophageal component. Like this is how a embryological arch is right in the center. Now there are other variations which part degenerates and gives rise to a ring kind of structure. So type 1 I have already described will not cause any problem because everything is in front of esophagus and trachea or back of esophagus or stridor. Nothing encircles them. So accordingly, there's a type 2 which we had seen in baby Kimika, where you had a aortic diverticulum giving rise to a ligamentum arteriosum causing a complete ring. This one also uh, uh, is type 3. Sorry, the baby Kimika was type 3. We had a subclavian artery arising from this diverticulum. And then the type 4, where everything arises from this encircling arch. Then there are other rare types of anomalies which we really don't see, but for the sake of completion, there is a left-sided aortic arch with a right-sided descending aorta. This per se will not cause any problem unless you don't have a ligamentum arteriosum, which helps to form a complete ring. Then you have a cervical aortic arch. If I was audible at that time, I told you that usually aortic arch arises from the fourth embryonic arch. But when it arises from the third embryonic arch, there you found a high up cervical aortic arches, which usually present with a palpable mass in the neck and a pulsatile mass in the neck, which can cause tracheal obstruction at various levels. Then you have incomplete vascular ring. Dr. Gaurav has mostly described it, but usually a pictorial representation imagining what exactly happens anatomically. This is a left aortic arch with a retroesophageal right subclavian artery. Usually, it remains benign for very long time unless you don't have a diverticulum that is formed at the base of the left subclavian artery. Or this this right subclavian artery does not give rise to a ligamentum arteriosum, which forms a complete ring. Then you have a tracheal compression by brachiocephalic artery or a left carotid artery. You can see how this innominate artery is compressing the trachea. So these are one odd findings that you see. Another very rare presentation is a pulmonary artery sling. The diagram will itself give you an idea what exactly it is. Here, the pulmonary artery does not arise from its usual position. That is here. It arises from the right pulmonary artery, goes behind the trachea, and gives rise to a sling-like condition, which can cause compression either of the esophagus or of the trachea. So now coming back onto the indications of surgery, it is simple. There are there's no ambiguity in the indications for surgery. Any patient who has an obstructed airway is a candidate for surgery. Usually, dysphagia is not very common in initial part. Most common problem that you have is a stridor. And when there is associated symptoms with stridor, like intercostalization, baby is tachypneic, failure to thrive, this is a straightforward indication for surgery. Then, if there are various schools of thoughts, but mild or absent symptoms, they don't warrant surgery. they can be followed up. So the surgical approach depends upon the anatomy of the uh, baby, of the exactly the aortic arch. We can do it through the sternotomy, which we have done in both of our cases that Dr. Gaurav has mentioned, and we can do it through thoracotomy on the right or the left side, depending on the what is the cause of that arch. Again, we'll go into the diagrammatic details, not in very detail. I'll just give you a brief diagram of how the surgery looks like. In cases of double aortic arch, if you can see the diagram, this is the thoracotomy view of the aorta, the trachea. There's an arch which goes behind the trachea, and there's an arch which is on the left side of the trachea. So what we do is, we like PDA, we just ligate it here and excise this issue and excise the ligamentum arteriosum. So you have a free arch and the ring has been broken. In some cases, what we do is we tuck this part of the aorta to sternum. That is called the aortopexy. So this is the problem of Microsoft 365. Okay. Then you have a repair of right aortic arch with a retroesophageal components. So again, not much in detail. The most important concept is of this diverticulum that is available, that is usually present. Many studies, they tell that this diverticulum has to be excised, but it is easier said than done because the tissue there is very fragile. Sometimes the quality of tissue is like a PTA. So you tend to have a situation where it has to be usually put a patch on this. Then if you can again go back to my previous slide where you had this diagram. So there are various areas where we excise the tissue to relieve the obstruction, or the main purpose is to convert a complete ring into an incomplete ring. So like in baby Kimika and the other baby that followed after baby Kamika, what we did was we excised this ligamentum arteriosum. Though they had a very big PDA, it was not a simple ligament available. There was a big PDA available, PDA there. So we had to excise this so as to uh, uh, what you call make it into a incomplete ring to give them a breathing space. Then again, when you have a tracheal compression by a brachiocephalic or a left carotid artery, you either by sternotomy, you reposition the innominate artery right in front of the trachea to a bit on the side, or through thoracotomy, you can do a you can do a innominate pexy, where you pull this this innominate and fix it to the anterior sternal wall. Again, artery sling. If you can see the diagram that I had mentioned, that the main pulmonary trunk is giving rise to right pulmonary artery, and the right pulmonary artery is giving rise to the left pulmonary artery. So the problem occurs is, if you can see this dotted diagram of trachea, there is compression of trachea mostly, and there are ways to treat this. If you can do a sternotomy, go on, disconnect this left pulmonary artery and reattach it to the main pulmonary artery. If the anatomy is more feasible, you can do a off-pump repair through thoracotomy, where again the same thing is done, but without using a pump, and you excise any ligament that is available. So just to, I hope you understand what the very rare congenital anomaly. Only severe symptoms can be kept under close observation, and we can go ahead and do a surgery if they start to develop some symptoms. Then again, as Dr. Ritika had also said, there are conotruncal anomalies associated with double aortic arch. So obviously, in our centers, we'll obviously evaluate through echo, but in general practice also, tetralogy of fallow, truncus arteriosus, double outed right ventricles have to be ruled out before we go ahead and plan the surgery. Uh, are there any questions or any queries? We can take that.
There are no more questions on the chat box. Dr. Ankit, could you please summarize and tie up?
I think I want to say something that it's a wonderful delineation by Tarun of the anatomy of the aortic arches and the way they form the complete ring or incomplete ring. And the only thing we should understand is that what we have to do surgically is that we have to make that complete ring into a incomplete ring, so that the trachea and the esophagus are not compressed. And by doing that, we are relieving that ring.
Thank you, Dr. Gaurav. As I said, it is the anatomy that is complex. Surgically, it is not a very difficult thing to do, but we need to be very sure that the baby requires that procedure or not. Both are babies.
Yeah. So sometimes we are not able to extubate these babies after surgery.
Yes, yes.
Tracheal damage which has already been done by these rings, and there is a severe tracheal damage and tracheomalacia that Dr. Ankit can tell us, and then these cases become really difficult. These are difficult to extubate.
No way of knowing before the surgery. There is no way of knowing whether the child also has malacia or not. That we can only after the surgery.
Absolutely.
Once the compression is relieved, there are high chances that the child might have malacia because of chronic obstruction. So that we can only know if the child requires positive pressure ventilation for long, or if the child has increased work of breathing. So we do a bronchoscopy and we find out malacia.
Sometimes these kids require repair of the trachea also, or branches of the trachea. But that is very cumbersome procedure. Some centers they are doing it, but
one thing that we can do to check for airway patencies, we can do bronchoscopies during the surgery. Intra-op bronchoscopy can guide the surgeon whether the airway compression has been relieved sufficiently or not, or if there is any residual malacia, whether they need to do an epexy. So that is one thing that we can go.
Yeah, so I think it has been a wonderful session. We do understand that these are rare problems which everyone may not see in day-to-day clinical practice. So to summarize here, children who present with wheezing which doesn't fit into your normal multi-trigger wheezers or episodic wheezers, they tend to wheeze frequently or they tend to wheeze persistently. They do not improve with the routine treatment, and having other red flag signs like starting at a very early age, in less than 6 months, having repeated hospital admissions. So these are the candidates where we need to evaluate them for other causes. So vascular anomalies would be just one of the cause of a child who presents to you with a wheeze which doesn't fit into or an atypical wheezer. Now, similarly, children who present to you with stridor, we understand that most children will be otherwise well, and the chances of this being laryngomalacia are significantly high. But if you have a child who is unwell, who is not growing well, a child who has severe stridor, a child who has retractions, a child who has failure to thrive, a child who requires some sort of a respiratory support, then again this is a group of children who possibly require the evaluation. And again, as I said, you can have multiple causes, and vascular anomalies is just one of them. But it is worth investigating these children because many of the causes are treatable, and if you make a diagnosis in a timely fashion, then the outcomes can be significantly better. It definitely requires a team approach. If we diagnose any compression uh, on the bronchoscopy, we have to go ahead and get a CT, and we also require a detailed echo. because a lot of tracheal anomalies are associated with cardiac problems, and similarly, cardiac problems can be associated with a lot of airway issues, like sometimes tracheal stenosis or malasias and so on. And I think if you have a surgeon in your team, especially a wonderful surgeon like Dr. Tarun, then your life becomes much more easy. So I would thank everyone, all of my speakers, for a wonderful session, and thank you to all the listeners. The recording of the TELE-PEDS will also be available, and we'll share that soon. So thank you very much, and I'll hand over to Dr. Swati.
Thank you, everyone. Next month, we will be back with another interesting session, and we will circulate the recording of this session soon. Thank you, everyone.
Thank you. Thank you. Good day.